Hello, everyone. I'm Dr. Joe Ravenell, and I am honored to be here. Um, I am here out of the kindness and generosity of Mrs. Beatrice Welters, who I have had the pleasure of knowing for the last 5 or so years. And I've heard so much about the AnBryce Foundation. And so it gives me great pleasure to be able to actually speak to members of the foundation today. I'm going to be talking about my work as a primary care doctor and as a health equity researcher. My life's work has really been dedicated to figuring out how we can eliminate health inequities that disproportionately impact Black men. And colorectal cancer is one that I have been focusing on, namely because it is one of the few cancers where we know precisely what we need to do to prevent it. And we know that timely screening really gives us the ability to identify precancerous lesions, or literally warning lights that a cancer is developing. And we can actually see those warning lights, those polyps, they're called, and remove them if we can identify them in time. So my work has really been focused on how can we connect more Black men um, to that life-saving screening test sooner and more broadly. And we all know that 2020 has been just a very difficult year for many reasons. Because of unforeseen tragedies, because of COVID-19, and because sadly of colorectal cancer, we have lost too many of our great Black people, too many of our great Black men during this year. And Chadwick Boseman is absolutely one of those great men. To even look at this headline makes me emotional because I am 46 years old. He was 43. Of course, he had such an impact on the world, but he certainly, in portraying the Black Panther, that superhero that I never had a chance to see when I was growing up, for him to project and portray an image that my kids could identify with, and really strive to be their own version of a superhero. Thanks to him, his passing was definitely difficult for all of us. But I think what's even more difficult is what he passed from. As we know, he died from colorectal cancer. I certainly didn't know that he was struggling with that, but the fact that he died so young means that he most likely had um, what we call early onset colorectal cancer. And sadly, it is a phenomenon that we are seeing more of. And the traditional teaching has been that people who do not have a family history of colorectal cancer, that they really are at greatest risk for what we call average risk of colorectal cancer that is not related to a familial or a hereditary syndrome. We think that age 50 really is when people should have been getting screened. That was what I learned in medical school, and really what the teaching was up until recently, when we started to see a marked increase in an early onset colorectal cancer in young people, just like Chadwick Boseman. And so we certainly have our work cut out for us in terms of trying to figure out what is going on. I just want to show a graphic that shows the median age at colorectal cancer diagnosis in the U.S. Over the last 30 years. And what we see is that in 1990, the median age at diagnosis, and median is basically is a mark where essentially it's the 50% mark basically, and so 50% of people get diagnosed get diagnosed later than the median. 50% of people get diagnosed before the median. So it's similar to the average. It's not quite the average, but what we can see is that median age has steadily dropped, and where now the median age is down to about 66. So it's decreased by 6 years over the last 30 years, which doesn't sound like a lot. But what that means is rather than 50% of people being diagnosed below the age of 72, now it's below the age of 66, which means that many more young people are being diagnosed with colorectal cancer. So we're trying to really think about and figure out why we are seeing this. And this is really an emerging field where we're learning more and more every single day. But this comes from a paper from folks at the American Cancer Society that really has identified some exposures or of risk factors that definitely deserve more attention. And so this list here of about 10 things or so, these have not necessarily been proven to be the cause of the rise in early onset cancer, but they definitely are important candidates that we should be looking at more. So Westernized diet, which sadly is comprised of many poor nutritional elements, including high salt and high fat, um, red or processed meat. Obesity. Certainly, we are continuing to see a rise in obesity across our U.S. population, but we tend to see it more so in populations of color. Stress, perceived stress, is also something that we are looking at that may explain the increase in early onset colorectal cancer. More use of antibiotics, where you are essentially changing the flora and the composition of your digestive tract, and potentially making it more susceptible to cancer. And as I present this, this is not to say that antibiotics are bad. They are not bad. They have certainly been life-saving for many diseases, and we know the reason that we have overcome many communicable diseases is because of antibiotics. What I think is listed here is really kind of indiscriminate use of antibiotics, using them when they are not necessarily called for, and in resistance to antibiotics, and can definitely have an impact on the gastrointestinal tract. Synthetic dyes, monosodium glutamate, which is an additive that I think those of us who are part of my generation and older, we associated with Chinese food, and it's MSG for short. But we know that people can be allergic to MSG, but we believe that it also has other potential harmful effects other than just causing an allergy. Titanium dioxide is a substance that we find in cosmetic sunscreens and other types of cosmetics, and in some experimental models, titanium dioxide has been demonstrated to potentially increase the risk of cancer development. And then high fructose corn syrup, another substance that is all throughout our diets. It's in all of those delicious tasting sugary drinks. And we know that in addition to contributing to cancer risk, it also increases risk of diabetes and a number of other chronic diseases. So these are all things that we are looking at as potential explanations for the rise in early onset colorectal cancer. I don't really have much information about Chadwick Boseman's cancer in particular. I don't know if he had a family history or what contributed to his early onset of cancer. But we're going to talk a little bit more in the presentation about how we should be looking at screening for colorectal cancer, depending on your specific risk category, which definitely includes family history. So, going back to Chadwick Boseman, while I don't believe that. So while I believe that his early onset cancer still is much less common than the cancer that we see in people who are 50 and older, his passing certainly was an important opportunity for us to talk about colorectal cancer in Black men. Black men have a higher both incidence and mortality rate. So the incidence rate is how likely you are to actually get a certain disease. Mortality rate is how likely you are to die from it. And Black men have the highest incidence and mortality from colorectal cancer of any other group in the US. We don't understand fully why that is, but this slide that shows the disparity between Black men and white men, where Black men are essentially 30% more likely to die from colorectal cancer compared to other groups. This is the slide that often gets me out of bed in the morning, because again, we do believe that colorectal cancer is preventable with timely screening and diagnosis. So what we see here is a critical health disparity. And so what are health disparities? Health disparities were actually officially defined by our government as part of the Minority Health and Health Disparities Research and Education Act in 2000 under President Bill Clinton. And essentially, disparities are defined as an overall difference in the rate of disease incidence, prevalence, morbidity, mortality, or survival rates with regard to a specific condition or a specific population. We like to think, however, much more broadly about health, not just in terms of different disease rates of certain conditions, but really, what are we looking at in terms of the totality of health? And so we like to think more about health equity rather than just health disparities. So the Robert Wood Johnson Foundation has defined health equity as it means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So, health disparities really focuses, I believe, too narrowly on just health conditions and disease, whereas we know that health has so much more involved. And we think a lot about what we call social determinants of health. And I and many others believe that the social determinants of health are just as important, if not in some cases more important, than the genetic contribution to disease. So there are, there's one other concept that I wanted to talk about, which is health justice, and certainly during this time where COVID has demonstrated a real lack of both health equity and health justice. And I believe that right now, at this time, when there is a call for racial justice, we have to consider health justice as well. And so, how do we think about health justice? This comes from the Network for Public Health Law, and they describe health justice as including health equity, dismantling the effects of racism, and working towards sustainable policies and innovations that will last through generations. They also define it as equal access to health information and care and equal protection under the law to ensure a healthy and safe environment. And lastly, they say health justice is a collective concept that should be considered a fundamental human right. So I just wanted to talk about those guiding principles that I think have really guided my work and my career. So, what do we think contributes to the fact that Black men have a higher incidence and mortality rate from colorectal cancer? There's no question that lack of timely screening definitely plays a critical part in this inequity that we see. New York City data has demonstrated for the last 12 years and this data has not really changed over that time frame, that Black men are much less likely to be screened in New York City before the age of 65. And if the screening age is at 50, and now we actually believe that the screening age should be lower, as in age of 45. The fact that Black men are less likely to be screened before the age of 65 points to a real problem, which we have tried to address. Another important challenge is that Black adults generally are less likely to have diagnostic follow-up after an abnormal screening test with regard to colorectal cancer. And we sadly see the same pattern in other cancers, such as breast cancer. So it's one thing to get a screening test for a particular condition, but not following it up and not figuring out if there is a true problem and getting all the way to diagnostic resolution, we consider that an incomplete screening. And so the fact that Black adults are less likely to have diagnostic follow-up means essentially that a number of adults, even when they get screened, are not having a complete screening. And so those are that's really where our work has focused on trying to both improve screening, but also improve follow-up for abnormal screens. So when we look at the problem of colorectal cancer screening in Black men, we know that there is that Black men who are 45 and older really should be screened. But in order for that to happen, there typically has to be some engagement with the healthcare system. And that requires men or patients actually entering and engaging with the healthcare system. And then once the patients present to their providers, it's up to the provider to actually make an appropriate recommendation for colorectal cancer screening. And once that referral is made, it really is incumbent on us within the healthcare system to try to make sure that that we facilitate them actually being able to take advantage of that referral and to actually get screened. But we know that there are a number of barriers along the way. Healthcare seeking behavior, we know, is suboptimal in men compared to women. Generally speaking, women tend to be much better about looking after their health and actually engaging in primary care. There are a number of explanations for why men don't go to the doctor as much as they often should. Certainly, uh, the notion that if it doesn't hurt or if it's not broken, I don't need to tend to it. That tends to be a fairly common masculine attitude that we have looked to change in many contexts. But even when there is a man who is willing, often there are barriers such as cost and access that can prevent Black men from getting the care that they need. And then fear, we know, is definitely an important barrier. Fear of a bad diagnosis, right? People are often afraid of actually getting the diagnosis of cancer. But then also, we have learned in our work that there can be fear of engaging in the healthcare system because of negative experiences, either personally experienced or experienced indirectly by knowing someone who has had a negative experience within the healthcare system. And unfortunately, the majority of men that we have engaged in our studies have either had a negative experience themselves or they know someone who has. But then, even when men go to the doctor, they get a referral. It's not terribly easy to actually uh, figure out what you need to do to actually get screened. And this is where the role of navigation comes in. And it really is where we have dedicated the majority of our efforts to making sure that we can actually take people by the hand and guide them to where they can get this life saving screening. So one of the challenges that I mentioned is access to primary care. This slide comes from work that we did in Dallas, where we interviewed over 6,000 men and women, and found that Black men were much less likely to have a primary care doctor, and that was due to a number of reasons, including trust, including access, and this notion that I don't need a doctor if there is nothing acutely wrong with me. And so we know that we are not engaging men in the way that we need to in the primary care setting. So, how then can we reach Black men? And two really important cultural institutions that we have looked to include the church and the barbershop. This is a picture of my church from when I was in Dallas, Friendship West Baptist Church. Reverend Dr. Frederick Haynes still continues to be an incredible inspiration and mentor to me. But then the barbershop is a very unique and special place for Black men. It's a place where we go for solace. It's a place where we go for support, for camaraderie, for friendship. And it's a place where we know we're going to run into people who have likely experienced many of the challenges that I have in order just to get to that next barbershop appointment. And there's nothing like being with a group of other men that you can talk with, that you can share with in confidence. And there's a whole range of topics that come up in the barbershop, and health is absolutely one of them. So, why churches? Churches are in every single neighborhood, particularly here in New York City. In areas like Harlem and Brooklyn, you can actually find a church on just about every corner. They're a trusted non-medical site, and believe it or not, many Black men still go to church, despite the common perception that we do not. But we have found through national surveys that the majority of Black men still do attend church, and particularly in the age group that we are talking about, age 50 and older. But the barbershop is absolutely a place where you're likely to find an incredible cross section of men from all different walks of life. Um, and the barbershop has become very popular. LeBron James has a show called The Shop. There have been, as I showed on the previous slide, several movies, really giving a kind of inside look at what happens in barbershops. And it's been thought of as the Black Man's Country Club, a relaxed non-medical atmosphere, a place where our research has shown we go every month at a minimum, but often it's even more than that on average. There's a tradition of barber surgeons where back in Renaissance days, barbers did much more than just cut hair and give shaves. They actually used to do minor medical procedures. So this intersection between barbering and health is not a new idea. And then we know that barbers are key opinion leaders. It's been said many times that some Black men trust barbers more than they trust their doctors, and it's because of the relationships that are able to be built when you go and you talk to someone, you see someone month after month after month, which is very different from how men engage doctors. This is one of my favorite pictures. It's a picture of my son, Asa, getting one of his first haircuts from my barber, Mr. Mahir, who is right down the road in Montclair, New Jersey. So this, seeing this photo, it also makes me emotional because it just reminds me of just how fast my kid is growing up, but also reminds me of why I do this work, because by the time Asa gets to 50, I want to have this figured out. I want to have it so that when he is of age to be screened, that there are no disparities. And that really is what keeps me going. So I mentioned before social determinants of health. We know that much more goes into health than simply health care. And this is a model by some of our colleagues at NYU, as well as the great Dr. David Williams. I like to think of him as the godfather of racism and health. Really, through his incredible work, has shown a light about on how concretely and materially racism negatively impacts health. And so when we look at this diagram here, we see three levels of determinants. We see the macro level, we see what we call the meso level, and then the proximal level in terms of how it impacts on health outcomes. And the very first social determinant listed here is racism. I believe racism is the most important social determinant for Black people, hands down, bar none. And we can see that we're not the only ones who feel that way, because racism impacts all of these other macro determinants. And of course, because of systemic racism, because of racist policies that have resulted in essentially differential opportunity to things like fair and clean housing, financial security, occupational opportunities, differences in safety of neighborhoods. That's all rooted in longstanding systemic racism that we have to find a way to dismantle if we're really going to talk about health equity. But we can see that racism impacts not only stressors and survival needs, but also medical care and access to medical care, psychological resources, but also social resources. And all of these things ultimately impact health behavior, which includes cancer screening, which ultimately impacts on health outcomes. So we were very blessed and fortunate to have competed successfully for several NIH National Institutes of Health grants that funded the Men's Health Initiative. 2 projects, 1 goal. One project was focused on improving screening rates among Black men in churches. The other was focused on improving screening rates among Black men in barbershops. And so what we proposed was that, if we could identify men in barbershops or churches and actually navigate them, that we could actually have an important impact on screening rates within this population. So patient navigation is a concept that was really coined and popularized by the great Dr. Harold Freeman, who at the time that he coined this was doing really important work, both in Harlem, but in many other parts of the city and the world. And really, the idea was that we would be able to not only navigate patients to where they could get screened and diagnosed for cancer, but just as importantly, navigating them to where they could be actually screened and treated. We know that the medical system is fraught with complexity and confusion, and navigation really offers a way to give patients a kind of personal GPS to be able to navigate through the healthcare system. So we had a number of sessions that we did in the barbershop setting to help men understand colorectal cancer, the unique risk that it has for Black men, the need for screening, but not just that, but how we could actually direct them to where they could actually be screened within the next 6 months. So these are just some data from our 2 projects. The Mr. B project focused in barbershops and the Faith CRC project focused in churches. All told, we were able to include over 7,000 men over the age of 50. But in order for us to get to that 7,000 men, we actually had to do outreach with over 20,000 men and women in barbershop and church settings. And that's something that we're so extremely proud of. The fact that we were able to leverage the research and research dollars in order to actually serve our community with this important education, information, and outreach. We worked with over 200 community sites, including barbershops, churches, soup kitchens, health fairs, social service centers, senior centers. And this is just a depiction of all the different sites that we were able to work with throughout all 5 boroughs. These are some of the characteristics of the unscreened men that we were able to engage in our studies. On average, we identified men who were 55. For the most part, they were born in the U.S. and were English speaking. We see that only 25% of the men were currently married or living with a partner. 18% were divorced, but 40% of these older men were never married. And it really, when I think about all of the good choices that I've made with regard to health, my wife has really been the reason for that. And so, I'm of course putting in a plug for marriage, but also I think it's important as we think about how to address health inequities among men, to really think about how we can partner with the wives or other loved ones in their lives, because they are so such an important source of support and encouragement for men doing what they need to do for their health. So these are some more of the characteristics of the men that we encountered, and we can see that we were able to reach a fairly disadvantaged group of men. $17,000 per year was the annual reported household income for on average for the men in our studies. And this is also really important. Nearly half of them currently used tobacco products, which we know is a very important risk factor for all kinds of. So result of study, basically, where we linked men either with usual care, which was essentially just a referral to where they could be screened for colorectal cancer, or to patient navigation, where we partnered them with a patient navigator who guided them through the process. And what we saw was, by putting a patient navigator into barbershops, that we were able to increase the likelihood that they would be screened in the next 6 months by about 4 times, which is amazing. And so what we learned, the kind of take home points were that the men that we linked with patient navigators in the barbershop were more than 3 to 4 times likely to get screened, compared to those who did not get navigation and who just got a referral from their doctors. Um, and that this patient navigation intervention was just as effective in people who did not have health insurance as those who did. And it also was effective no matter what your level of health literacy was, which is really, really critical. These are just some pictures from the effort. We utilized a mobile van often to do the outreach. We worked with a very diverse group of team members, but also we were able to work with mosques, as well as a number of churches. And these are two of my favorite team members, Patricio Castillo and Lloyd Giamfi. I'm so proud of so the reason that I want to mention this photo is because Patricio, he started out with me about 7 or 8 years ago, and he is now a second year medical student at NYU Grossman School of Medicine. So whenever I see him, I'm just so inspired by him, also by how we were able to both impact our community, but also to have an impact on the future of medicine and our communities. We learned that the secret sauce to us being able to reach Black men was to have an incredible team of navigators who were personable, dynamic, and fearless. We had to make sure that we were in the right hot spots, but also that we knew that we could not just engage men once. We had to keep going back over and over again, and that's the kind of dedication and commitment that is necessary, and that our team was able to provide to have the impact that we saw on colorectal cancer screening. So I wanted to just acknowledge all of the incredible partners who were a part of this work, including our Perlmutter Cancer Center at NYU Langone Health, and of course the NIH and CDC for all of their generous funding. I also had an opportunity to give a TED Talk about our work in the barbershops, and to really feature uh, to, to feature the barbers and how important they have been and continue to be to our community and to the future of our health. Um, I also, as a result of this, to really, I believe, enabled me to have the opportunity to get to know Mrs. Welters. Um, the Welters Breast Health Outreach and Navigation Program. Many of the outreach elements were modeled after this colorectal cancer work. And so there has been no greater reward than seeing this work grow beyond colorectal cancer and to be able to include breast cancer. And so um, as I end, I just wanted to project this last slide that really talks about what we need to be doing to prevent colorectal cancer in our communities. And really, timely screening really is the key. This is somewhat of a complex slide, but I will make sure Jalecia has access to my slides so that you can view them in more depth at a later time. But what I want to get across from this slide is there are different risk categories for when you should be screened. And generally, if you have a family history of a first degree relative, you really need to be getting screened much earlier than those who do not have a family history or who are at what we call average risk. So if you are at average risk, meaning you don't have a family history, you really should be getting screened at age 45. And you can do that either with a colonoscopy. I was very proud to have gotten my screening colonoscopy during my 45th year. But there are a number of other ways to be screened, including very effective stool cards where you can actually put some of your stool onto a card. It can be analyzed in the lab, and we can actually see whether or not you are at elevated risk for a colorectal cancer. And there's actually one test called Cologuard, where it actually tests for the DNA of polyps or colon cancer, and we can actually detect colon cancer with this Cologuard stool test. Um, there are a number of familial or hereditary syndromes where people need to be screened early. One called familial adenomatous polyposis or FAP syndrome. So please, if you have not, looked into your family history to see if you might have either FAP or Lynch syndrome, it's really important that you do so because you really need to be getting colonoscopies very early on. If you have a first degree relative with who has had colorectal cancer, meaning a parent or a sibling, you really should be getting a colonoscopy starting at age 40 or 10 years younger than when that first degree relative was diagnosed, whichever comes first. So it's really important to know your risk category because it really determines when you need to get screened. Other things that we can do to try to prevent and reduce our chances of getting colorectal cancer include improving our diet to be much more vegetable based, much less meat and processed foods based. Try to focus on a healthy body mass index. Try to have regular physical activity. We really should be exercising 30 minutes or more on 6 or more days of the week. And that can be walking or it can be more vigorous exercise. We really want to try to avoid sedentary behavior, which I know is very challenging as we are all stuck in front of our Zooms because of the pandemic. And then lifestyle. We really have to smoking, there's nothing good about it. If you currently smoke, we have to work on quitting completely. And if you do not smoke, do not start. And then limit sugary drinks as well as alcohol. So with that, I'm going to end and hopefully leave enough time for questions. But I did want to just thank Welter Thank you for the opportunity to speak to you today. More than happy to answer any questions that you have. Thank you.
Yes, Dr. Ravenell, I have a question, and that is, w- you talked about Black males, and I do know, what about females and
Great question.
where can others of color and whites go to find out about their
Yes.
colorectal rates?
Yes, and so thank you for that for that question. And so while my work really has been largely on colorectal cancer in Black men, there's no doubt that it also impacts Black women greatly. There is a disparity between incidence and mortality of colorectal cancer for Black women compared to white women. Unfortunately, Black adults do worse in terms of colorectal cancer compared to white adults. We are still learning about colorectal cancer in other racial and ethnic populations, but what we do know is um, that lack of timely screening is a risk factor no matter who you are, and we know that because of access, because of the greater likelihood of not having health insurance, that populations of color are at higher risk of both getting and doing poorly from colorectal cancer. And so, thank you so much for that question, um, uh, 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 Mrs. Welters. And through your program, through the Welter's Breast Health and Outreach Program, we, in addition to providing breast cancer screening outreach, we also have been able to provide outreach, education, and screening related to colorectal cancer because the age groups overlap greatly. But when we're talking about risk for breast cancer and risk for colorectal cancer, so what I can recommend to to women is, as you are talking to your providers about screening for cancer, please talk to them as well about getting screened for colorectal cancer because age 45 really is the age at which you should be discussing both with your provider. Are there any other
Thank
questions?
you.
Of course.
This is Sarah Kabinski from the AnBryce Scholars Initiative at Notre Dame. One, I'd like to thank you. You gave really good information that was very holistic, and I have already texted Amanda, who I work with, to see if we can incorporate it into some plans that we have to grow our insurance for our students. But one thing I wanted to ask, in this time of COVID-19, where people are very wary of going into hospitals and doctors' offices, what is your recommendation for ensuring that they are still on track for screenings?
Excellent question. And thank you for that, Sarah. So I would recommend definitely keeping on track with your primary care doctor's visits. It is safe to go into healthcare settings. We all when we came back to our medical centers, we all had to be tested for COVID. We all have to daily, do symptom checks, and there is regular surveillance for COVID. So we do believe that it is safe to go into healthcare settings. Everyone, has to wear masks. Like it's not even a question. Employees have to wear masks. Patients have to wear masks. So I would encourage you to continue to keep up with your primary care doctor's visits, and your primary care doctor should be referring you for the screenings that you are due for. And as I mentioned, I got my colonoscopy done. I work very closely with the people who do colonoscopies. It is absolutely safe to do it even during this time. My wife went to get a mammogram last week. And so I would encourage whatever screenings you are due for, it is safe to do it. Do not wait. Do not delay. Please stay on top of your screenings because the best weapon that we have against cancer is early detection. There's no question about it. So please do not delay.
Hi,
Thank
Dr.
you.
Ravenell. This is Jay.
Hi, Jay.
Hi, can you talk about the importance of primary care physicians? Because I think sometimes when people have specialists, they tend to go to their specialists rather than having a primary care. And if they are being seen, they may not realize potential risk factors by not having one.
Yes. Thank you so much for that question, Jay. So, and full disclosure, I am completely biased when it comes to this because I am a primary care doctor. But I believe everyone needs a primary care doctor to be able to coordinate care. If you simply just go to specialist after specialist, things will no doubt fall through the cracks. And it really is important to have someone who has a full picture of your health to be able to coordinate things and to be able to follow up when there are abnormal tests. One of the great kind of safeguards that we have in medicine is redundancy, right? Where if something gets missed by one provider, right, there is theoretically another provider who's there to make sure that nothing gets missed. And so when I refer a patient for a mammogram or for a colonoscopy, or I refer to a specific doctor usually, and if I have not heard from that doctor after a certain amount of time goes by, I have my staff check in to say, did this person have that test? If they did, what was the result? If they didn't get the test, why not? And primary care doctors are that critical kind of backup to make sure that whatever happens with a specialist, that comes back into your kind of universal file, and whatever follow-up needs to happen beyond that actually gets taken care of. And so, there is no better coordinator in medicine in terms of doctors than our primary care doctors. And from you when you're younger, that primary care doctor is your pediatrician. Just because you leave your parents' insurance doesn't mean that you don't need a primary care doctor anymore. It mean you actually need it even more because mom and dad are not there looking after your health, and so you need someone to help coordinate your care. And so, thank you, Jay, for that opportunity to plug my specialty.
Problem.
Hi, Dr. Ravenell. I have a question as well.
Hi.
Hi, as someone who is an aspiring physician, I'm really interested in the ways that you've specifically engaged the community and used it as a resource in order to get people the care that they need. And so I know that Mrs. Welters does the same in terms of breast cancer, and you do so with colorectal cancer. I'm wondering if you think that this model can also be used for things such as diabetes, heart health, and other things that we know disproportionately affect specifically the Black community.
So, Jalicia, I'm so happy that you told me that you are an aspiring physician, because I will absolutely follow up with you, so that we can, because one of the things that I do in my role as Associate Dean of Diversity and Inclusion is do whatever I can to get incredible talent as well as diversity, within our medical schools. So, absolutely, let's connect offline. This model of engaging communities absolutely can be and has been translated to some of the conditions that you're talking about. In fact, my team has we published a paper in the Journal of the American Medical Association demonstrating how our team has been able to do finger sticks in the barbershop to screen for diabetes. In fact, and before I actually started working on colorectal cancer, we started this work looking at heart health and hypertension in particular. And we have been able to demonstrate that it is an incredibly effective model for not only reaching Black men and women as well, but it also, not just for reaching, but for actually making a difference. We have actually been able to show that linking that by connecting to men in the barbershop and making sure that we actually connect them to doctors and pharmacists, that can result in a 20-point drop in blood pressure. I mean, that kind of impact is just unheard of. So so there's no question that it works. The challenge is, how do we sustain it? How do we pay for it? And so we are actually thinking very deeply about how we can scale this so that it can be these kinds of models can be covered by CMS, for instance, Medicare and Medicaid, because right now this work is largely grant funded, and I probably don't have to tell you, Jaleesa, you probably know how challenging it is to to have to apply for grants every couple years. I mean, right? But because we've been able to show impact, we really have to find a way to get some hard money to sustain this. So thank you for your question, and we will absolutely be in touch.
Thank you, Dr. Ravenell. I'm looking forward to it.
I see that one of my friends from Trinidad just got on. I hope there's Elaine. Elaine, I don't know how much of this you saw, but do you have any questions if you saw some, if you have any questions? You're on mute.
Sorry. Thank you so much. When the invitation came, it said 11 to 12 EST, and I know we're on AST.
Oh,
So
Eastern
that's why,
Standard Time. Okay, but anyway.
because we are on AST, and so I said, okay, I'll tune in just before 12. You all are now finishing?
Yes, it would have been great, but it has been recorded, so
Oh,
you will
good.
get a recording of it. But
Oh.
all righty, I'm sorry that cross-wired.
That's okay. Everything happens for a reason. I'm just sorry because I was here. I stayed home all morning because I said I don't want to miss this.
Okay, all
And
right.
there I did. I missed it. So
Okay, well, another time. You'll see it anyway.
thank
But
you. I'd love to. I'd love to. It's
yes,
great
so
to meet you again.
share it with all the people that you work with. Okay.
Take care, Elaine.
We have
All right.
in the chat from Dr. Kim says, I'm a community advocate for 50 years. My name is Dr. Kim Best. I partnership with several men's groups, and I would love to help. So just so that everybody hears.
Terrific. I would love to be connected, Dr. Best, and Jay and Jaleesa, you definitely have my permission to share my information widely. So, and you also, Sarah. So, feel free.
All right.
Just in the interest of time, I wanted to thank everyone for joining us.